Bismillahirrahmanirrahim. Today's our first question is a 20-year-old previously healthy university student returned 14 days ago from hiking through Asia. He complains of explosive, watery, and foul-smelling diarrhea of 6 to 8 motions daily. He has lost 4 kg in weight since his return. He is afebrile, pulse is 80, blood pressure is 115/75, and has abdominal distension. Examination of the stools shows they are greasy and contain mucus. Which one of the following is the most likely diagnosis? So since 14 days he had a diarrhea and a history of travel from Asia, and having a complaint of explosive, watery, and foul-smelling diarrhea of 6 to 8 motions daily. Vitally, he is stable and he lost 4 kg weight. So options are shigellosis, amoebiasis, Giardiasis, E. coli, cryptosporidal infection. So here he is having a 14 days history of traveling. So this patient is most likely to have a giardiasis, which is an infection mainly of the small intestine caused by the parasite Giardia lamblia. Transmission is most likely to occur if hands are not washed after defecation, by drinking contaminated water, and in rare cases through eating contaminated food. Treatment by isolation is not usually required, but advice about personal hygiene should be given. The most common symptoms of giardiasis are diarrhea, stomach cramps, bloating, nausea, loose and pale greasy stools, fatigue, and weight loss. The first sign of the illness will appear between 3 to 25 days, average 7 days after a person become infected. Most people who are otherwise healthy recover in 4 to 6 weeks. Occasionally, symptoms last for longer periods. It, it is important for people with diarrhea to drink plenty of fluids to avoid dehydration. The definitive medication is metronidazole. Each of the other conditions can cause acute or chronic diarrhea. Shigellosis, this is bacillary dysentery, is endemic all over the world and is particularly prone to occur in a condition of population overcrowding and poor sanitation. Fecal oral spread is facilitated by failure of hand washing after defecation. Diagnosis by stool culture and antibiotic treatment as prophylaxis is given for infection which are not self-limiting. Amoebiasis is due to a pathogenic intestinal amoeba, Entamoeba histolytica, and can cause amoebic dysentery or extraintestinal amoebiasis, amoebic liver abscess. Transmission of infection is again by the orophycal route. Diagnosis is made by identifying mobile trophozoites in the stool or from endoscopic scraping. Response to oral metronidazole is usually rapid. Travellors diarrhea uh, lasting usually from 2 to 5 days, particularly when visiting developing countries, can cause by a number of pathogens contaminating water, fruit, and vegetables. In the majority of cases, no organisms are identified and the condition is self-limiting without specific treatment. Severe and persistent symptoms can be due to E. coli and warrant antibiotics treatment. So that antibiotic would be ciprofloxacin. For Shigellosis also ciprofloxacin, and for E. coli as well ciprofloxacin. Cryptosporidial diarrhea is more common in immunosuppressed patient, HIV, or patient receiving cytotoxic therapy, would be less likely in this previously healthy man. Cryptosporidium parvum is a coccidial protozoa for humans and domestic animals. Infection is acquired by the fecal-oral route and may result from contaminated water supply. Symptoms are of diarrhea and abdominal pain, usually self-limiting but with potentially devastating consequences in immunosuppressive patients. Diagnosis by demonstrating oocyte and microscopy. The organism is resistant to most antibiotics, and treatment is usually symptomatic while awaiting resolution.